So let's start. People will join later.
Yes, please.
Yeah. So hello everyone. Assalamu alaikum. I am Fiza Gilani and I welcome you all for the third session of the HIV Awareness, Prevention and Education project in Pakistan. This project is jointly designed and led by APPNA-MERIT HIV Committee, the Common Management Unit, HIV, TB, Malaria, Government of Pakistan, and the Medical Microbiology and Infectious Diseases Society of Pakistan. And pretty soon our Primary Care Society of Pakistan will be joining us too. I would like to introduce today's moderator, Dr. Muzammal Habib. Dr. Habib graduated from the Punjab Medical College, University of Punjab in 1997. Currently, he works in Massachusetts, USA, and is affiliated with Lowell General Hospital and St. Elizabeth Hospital in Massachusetts. He is board certified in vascular medicine and internal medicine with real passion for vascular medicine and cardiology. He is continually active in his professional life, highly accomplished, and is considered a leader in his field here in Massachusetts. He is a fellow with Society for Vascular Medicine and is an active member of Society for Vascular Ultrasound, American Heart Association, Massachusetts Medical Society, and APPNA, which is a New England chapter of APPNA. I welcome Dr. Habib, and he'll be moderating the session.
Dr. Gilani, thank you very much for wonderful introduction. Appreciate. Now, I think we will go directly without any undue delay to our presentation and our wonderful panel, which we have. And thank you for putting together, thanks to you as well as to APPNA and APPNA-MERIT to have a wonderful panel, very accomplished panel, which will be a lot of learning and teaching experience. So I will start from Dr. Saima Abbas. She is infectious disease specialist and she currently practices in Rockledge, Florida from 2010. She graduated from Fatma Jinnah Medical College in 1996, a well-known medical school in Lahore, Pakistan. She completed her internal medicine residency and infectious disease fellowship in University of Toledo, Ohio. She manages inpatients, infectious disease, including HIV, as well as rest of infectious disease patients in hospital, as well as in outpatient setting in her office in Florida. She is in academics and actively involved in teaching and training of faculty, as well as residents in hospital setting, and she supervises medical students during their internal medicine clerkship and rotation. Dr. Abbas, thank you, and it's all yours now. I think your microphone is off.
Yeah,
yes.
Thank you so much, Dr. Muzammil. It is good to be here. Thank you for the introduction. And I have two special thanks before we begin. One is for Fiza Rafiq, who actually approached me a couple of months ago to join APPNA Foundation to help contribute. And the second thanks is to Fiza Gilani, who has been she's the one who planted the seed for this webinar. And it has come to fruition, and we are so proud of her efforts and her passion and commitment. And if it wasn't for that, I don't think we all would be here. So thank you to her. So let me share my screen. Let me know if you can see it. Are you able to see it?
Not yet.
Can you see it now?
Yes, now we can see it, yes.
Okay.
Yes.
So let's begin. Okay, so I have taken the task of presenting clinical presentations and management of HIV/AIDS. So I work in a small hospital. It's a community hospital, and most of my experience is private practice. We have started bringing in academics in the last 1 year. So I felt that the one contribution that I could add to this topic was my clinical experience. So let's begin. Objectives are to identify the common and uncommon clinical presentations of HIV/AIDS and to recognize the traditional, the misinformed and the well-informed approach to diagnosis of HIV/AIDS. One thing I want to mention here is whether it is a resource-rich setting or whether it's a resource-limited setting, there are traditional responses which may not be accurate, and it happens in globally. So this is an important thing to know. Know the initial diagnostic workup and basic principles and goals of treatment of HIV. And I hope by doing all of this, I can decrease the stigma in healthcare workers when dealing with this very vulnerable population. So, the elephant in the room when you walk into an HIV patient's room is innocent versus guilty. And, when I came to the United States, as a fellow, when I started doing the HIV clinic, this is a story which was a heartbreaking story for me, and I thought it was worth historical mention. So this is the boy who changed the public perception of HIV in the United States in 1984. Ryan White, who I'm sure everybody who practices in the US knows him, was born in 1971, was diagnosed with thalassemia 3 days later, and ended up getting a lot of blood products, as you can imagine. And in 1984, when he was 13 years old, he was diagnosed with full-blown AIDS. So the moment he was diagnosed, he was kicked out of middle school. And that is how he made it to the news, because his mother was a strong advocate of education. And she said, I will not have my child deprived from this basic right to go to school. So she made it to the news, and this kid became the first innocent victim who changed the perception of how we look at these HIV patients. What ended up happening is he died in April of 1990. At that time, there was no treatment. 1 month before his high school graduation, and months later, Congress passed the legislation bearing his name in August of 1990, the Ryan White Comprehensive AIDS Resources Emergency Care Act. As you can see, the funding, which started with 257 million, reached 2 billion in 2020. And this CARE Act makes sure that they provide low income and uninsured HIV patients care all over the United States. So you can, the reason I presented this story was that today is 2021, everybody is big on social media, and we have plenty of Ryan Whites in Larkana, Sargodha, and Gujarat. And all we need is one story and a sincerely driven campaign to change the perception, because it is not helping these innocent victims. And that is why I felt any webinar coming from the US was incomplete without this story. So before I present any case presentation, there is a basic golden rule to HIV. There is absolutely no substitute to the test. If you have clinical suspicion, go ahead and test, regardless of the clinical picture and presentation. So remember, there is no infection, no presentation, then you cannot see in the non-HIV. If you see PCP pneumonia, you can see it in a transplant. You can see it in a chemo patient. You can see cryptococcal meningitis. I have seen that with bloodstream infection in a patient with myeloma receiving chemotherapy. So you can't say, oh, when you see PCP only then you have to check. You have to check then, absolutely. But there is no substitute to the test. Once the test is positive, then everything will start making sense. Secondly, a very important practical point that I want to make when you're taking histories and talking to these patients is that patients don't perceive their own behavior as risky. Therefore, they may not reveal pertinent history initially. So what will happen is when you will present them with the positive HIV test, then suddenly they will remember, oh, this happened 10 years ago, or this happened then, and most will revise their answers if the test comes back positive. So a healthy amount of skepticism is needed whenever anybody is saying they don't have any risk factors for HIV. If you as a clinician suspect it, just say, I want to be thorough, I want to be complete, let me just check you. And then if it comes back positive, then you can go inquiring into the sensitive and private sexual history or social history that they may not be completely straightforward about. So important thing to know whenever dealing with these patients. I want to start with case 1, and I did not know, Dr. Habib, that you were in the vascular field, but it's a coincidence that I chose this case. So this is a 68-year-old colleague, vascular surgeon, who called me within 2 hours of a needle stick exposure in the operating room while placing a tunneled dialysis catheter in a patient with known HIV and unknown hepatitis B or C status. So the surgeon reported that the needle penetrated the finger. He was wearing 2 layers of gloves, but he did not bleed. He washed the site of the needle stick promptly with soap and water. He was guided to the emergency room and employee health was contacted. The reason I'm presenting this case is that there are academic settings and there are hospitals who are aware of these procedures, but you may be in a remote area in Pakistan. You may be somewhere where you don't know that there should be a procedure or a protocol. So please know the procedure at your hospital and or your healthcare setting. And safe disposal of used needles in your office is something that is of absolute mandatory importance because of the histories that other colleagues have shared from Gujarat and Sargodha and all that has happened with the use of unsafe needles. There is a National Institute for Occupational Safety and Health, and I have put in this guideline if you need more information. This is another guideline for occupational exposure and what is the post-exposure prophylactic recommendations in the MMWR. It has been updated as well. Please refer to this if you come across this personally, or if any staff, whether it's a nurse, medical assistant, lab tech, radiology tech, or anybody or patient even gets exposed, not for patients, but any other healthcare workers, these are the guidelines. Basic principles. What is potentially infectious and what is not? So blood and bloody bodily fluids are potentially infectious for HIV. So feces, nasal secretions, saliva, sputum, sweat. You can wipe the tears off the child. They are not infectious. Urine and vomitus are not considered potentially infectious unless they are visibly bloody. So nosebleed or gross hematuria or blood in the vomit, that can be potentially infectious. The other important component is the exposure. Here I'm talking about needle sticks, but the exposure can be mucocutaneous or non-intact skin. And that is what, like, for example, a splash in the eye, or if there is a cut on your finger and you touch these, then it becomes significant. So you have to take every case on a case by case and investigate. So define the risk and assess the source. Is it a low risk? So if it's a solid needle, superficial injury, no visible blood, this is considered to be a low risk. High risk is a deep, hollow bore needle with visible blood. But if you don't have visible blood, you still have a deep, hollow bore needle, it still comes under the high risk category. Secondly, don't make HIV your blind spot. Hep B, and I know Hep C is more prevalent in Pakistan, so that also needs to be checked. I would hope that every healthcare worker in your office is Hep B vaccinated, but here it is mandatory that everybody needs to be vaccinated who's working in the healthcare field. So you have to assess the source. You can do a rapid HIV test. If they already have HIV, check a viral load to see if they are undetectable. The risk is way down. It's almost untransmissible if they're undetectable, which makes it low risk. Hepatitis B surface antigen and the anti-HCV antibody is what you need to check on the source patient. Please be mindful. Most of the times the source is not there, and I am cognizant of that, or you can't find the source. The needle was on the floor or somewhere else. Those scenarios can also happen. But again, you have to see what the exposure was and if you can obtain the source patient. So what is the best recommendation for HIV post-exposure prophylaxis in this clinical presentation? So, the traditional response is, and I don't know, it probably happens more often than any of us knows, it's a percutaneous low-risk injury, does not need post-exposure prophylaxis, which might be a number of cases. Percutaneous high-risk injury, source HIV is known. So do you use true drugs or do you use 3 drugs, or do you call an infectious disease expert, which my colleague did? Now, believe me, this was my first and final phone call. I don't get phone calls for needle stick exposures. We have employee health and emergency room. They basically deal with that. But because this came to mind, through a colleague's phone call, I realized that I'm talking to all my colleagues just to be mindful that this can happen, especially if the suspicion is low. So the answer is the standard of care in United States is to go a 3-drug post-exposure prophylactic regimen, because this is a percutaneous high-risk injury. There are some cases in which you can do a 2-drug post-exposure, but I would defer those to the infectious disease experts. And typically ER will prescribe the ART, so we don't have to get involved. What I used for him was raltegravir, which is an integrase inhibitor, and then two nucleoside reverse transcriptase inhibitors, tenofovir, emtricitabine. You give it for 4 weeks. You do HIV serology 0, 3, and 6 months on the patient, on the healthcare worker who has been exposed. And you obtain CBC and chemistry, because tenofovir goes to the kidneys and you may have to renal dose it. You may even avoid it if you have renal problems. You can use a combination of combivir, which is the lamivudine and azidovidine combination. So the surgeon colleague remained negative. Case 2. 35-year-old man presents to the urgent care clinic with 1-week history of fevers, chills, and a sore throat, along with body aches and headaches. He denies any exposure to anyone with COVID-19. He's not vaccinated against COVID or influenza. Exam shows that he's febrile. His heart rate is, he's a little tacky, 100. Blood pressure is okay, SATs are okay. So pharyngeal erythema noted on exam, no evidence of tonsillitis. There's painful oral ulcerations in the mouth. There's a faint generalized maculopapular rash, and there's shorty lymphadenopathy in the neck. He's leukopenic, white count is 4,000, hemoglobin is 11, and platelets are 130, so slightly thrombocytopenic, and transaminases are 2 times the upper limit of normal. Now, mind you here, this is very common in HIV patients, no matter which stage. So if you have a rash, look in their mouth. If you have a rash, check their lymph nodes. Even if you have a drug-induced rash story, still do this due diligence. I have been bitten by that. I had a lady who presented with a rash. It hadn't gone away 2 weeks after she had an antibiotic given to her. And that is when we suspected, why isn't this rash going away? And so just question every rash, no matter what story you get. And especially in that age group, when they're sexually active. Pharyngeal erythema, whenever you see a sore throat, I hope that people are looking in the mouth and seeing. You can even pick up thrush, which, believe it or not, is a very important clue when you're making a diagnosis of HIV, especially in AIDS. So what history is missing and most relevant in this clinical presentation? Sexual history, social history, especially traveling, history of polysubstance abuse. And in case of Pakistan, I understand even recent blood transfusion could be relevant, or any IV infusion for that matter, if they've been to a quack clinic, as has been mentioned. Any sick contacts, which is so common for viral illnesses, and any history of antibiotic use, or all of the above. So it's obviously all of the above. So patient denies any risk factors for any STI. He denies polysubstance abuse, but a urine drug screen is checked and he's positive for marijuana. His COVID PCR is negative. His influenza antigen is negative. His strep throat is negative, and his monospot is negative. So this is a common differential which any urgent care will check. So which virus is the most likely cause for this viral syndrome? So there is no correct answer here. It all depends on your index of suspicion and what history you get. So if 3 people in the house have influenza, it's probably influenza. If this is EBV, you should have a monospot, which is positive, but it is not 100% sensitive. So it still could be EBV, which is the way we misdiagnose HIV, because it presents like and a mono-like illness. HSV, primary infection, can look like that with oral cutaneous ulcerations. CMV, if you have a toddler who's going to a daycare, CMV can present like that. And my favorite, none of the above. So whenever we get, and this is as clinicians, we all get to that point where we have A, B, C, D as our most common differential, and E is none of the above, where there is uncertainty, we don't like being there, it's uncomfortable not knowing what's going on. So instead of whenever you get to none of the above, think HIV. Which clinical feature is a hallmark of HIV infection and helps to distinguish primary HIV infection for infectious mononucleosis? It's not pharyngitis, it's not rash, it's not cervical lymphadenopathy, and it's not the LFTs. Mucocutaneous ulceration should heighten the suspicion for acute HIV infection. The rash is less common in mono, except when antibiotics have been given, but is frequently seen in the setting of primary HIV infection within 48 to 72 hours. The heterophil test is typically negative. Mild anemia and abnormal transaminases can be seen in both presentations, and atypical lymphocytes and lymphocytosis is more common in mono, which was not the case in this patient. So this is the most important slide of this lecture. I learned this slide in my fellowship. It's easy to draw. I explain everything to my patients through this. Now, I don't know if you can see the left-hand column, but on the right side, we have the CD4 lymphocyte, the blue line on the y-axis. On the bottom is the timeline, and on the left, which I don't know, I can't see it. Can you guys see the left column, the red one with the viral load?
Yes, we can.
Yes, we can, yeah.
You can? Okay. So when a patient is infected, primary infection, you can see that the CD4 count is between 800 to 1500, which is your normal range. And so between 0 and 3 weeks, let's say the red line is the viral load, the blue line is your CD4 count. So what happens when you get infected, whether it's a blood transfusion, needle stick, IV drug use, sexual transmission, the viral load, so the virus disseminates. It seeds all the lymphoid organs, and the replication is massive. You see viremia, massive viremia, almost 10 million. It shoots up in the first 3 to 6 weeks, and it attacks the CD4 cells, which come down from 1,000. Here it comes down to 500. It never touches the AIDS count, which is less than CD200. Then what happens is that the CD8 cytotoxic cells wake up and say, what's going on? They try to control the virus, and the viral load comes down because your body is giving it an immune response and trying to control it. And after that, you go into a period of clinical latency, which is the chronic HIV stage, in which it can range from 2 years to 10 years, depending on your host factors. And here you come to a set point. That's what we call it, that it's low-grade viremia between 1,000 to 10,000. It will stay in that range for several years until slowly and gradually, as you can see, your CD4 count in a period between 2 to 13 years, it will hit 200. And that is where you will start to have constitutional symptoms, opportunistic diseases, and the mortality of an untreated AIDS patient is between 1 to 3 years. And if this is untreated, that's the timeline and the natural history. So primary HIV infection is usually missed, believe it or not, even here, because of the absence of a high degree of clinical suspicion. So symptoms are seen in 50 to 90% of patients, but guess what? Not everybody goes to urgent care or runs to the clinic for a flu-like illness. So this is usually missed. Secondly, it's self-limiting. If you wait long enough, symptoms go away. Thirdly, if you come in the window period, even if somebody checks you for HIV, there's a very high likelihood you could have the negative HIV test, because you have to check the HIV viral load, the RNA, in this setting if you come in the window period. So in this presentation, you can have mucosal ulcers, oral and esophageal, which could mimic GERD and PUD. And they have massive viremia. This is the most important teaching point of this. They are the most infectious, and this is where majority of HIV is spread, because they will not change their behaviors. They don't know what they have. And they are very high risk for sexual transmission. If they donate blood, or if they share needles during this period, they are highly contagious. Management needs prevention counseling. If your patient is going to get scared and run away, the one thing you need to tell them is, please don't spread it. And you can counsel them depending on their risk factors. Initial diagnostic evaluation of HIV patient is a mandatory. You have to make sure they don't have any other STIs, they don't have co-infections with Hep B, Hep C. So it's not just HIV positive, here's the ART and off you go. That's not, there's a whole workup that you need to do. Now, the older and the revised guidelines are recommending that you start ART if acute HIV is symptomatic. Now, urgently, when do you need to start ART? Highly symptomatic. I saw one case of rhabdo who presented with primary HIV infection. He was hospitalized. Mind you, these patients are typically not hospitalized. So he was hospitalized, so we started him on ART. Then with or without neurological disease. Now, neurological disease is a definite yes for starting ART in primary infection. Now, what is the practical ground reality? Most of these patients will literally not want to get treated. It takes time to adjust that you have this. There are other pressing issues. There's substance use, there's depression, there's concern that they won't adhere even if you start them or they are agreeable. And most of them may be unwilling to initiate ART. Once you cross the acute primary HIV infection stage, then I loved this WHO clinical staging because it tells you when to think of the disease in your patients. Stage 1, if anybody has lymph nodes in the neck or the axilla more than 6 months, think HIV. Test them. Ask them the right questions. There may be patients who will tell you that they have risk factors. Even if they don't, I would favor the test. Second, before the lymph node biopsy, definitely. Stage 2, mildly symptomatic stage, they have weight loss and they have recurrent respiratory infections. You give them antibiotics, they get better, but they keep coming back. And wide range of dermatological conditions. The skin exam, I mean, it is so much fun if you actually diagnose a skin condition and then trace it back to HIV. Lots of skin conditions, and dermatologists usually pick them up. Stage 3. So here you're getting into a moderately symptomatic stage. You're not AIDS yet, but you're getting weight loss. You have unexplained diarrhea. You have pulmonary TB. You have severe systemic bacterial infections, pneumonia, pyelo, empyema. I had one lady who was a diabetic. A1C was 11, and she kept coming back with, lost 3 toes. Now, why would I think of HIV? It wasn't until 6 months later that she was diagnosed with acute hypoxemic failure, respiratory failure, and came with PCP that we diagnosed her. But when I looked back, she was a poorly controlled diabetic who was having bone and joint infections. Mucocutaneous conditions, oral candidiasis, oral herileukopenia. I have also seen severe gingivitis. All the teeth are gone. Bad gingivitis can also occur. So all clues, if you see, you will find. And then the last stage is HIV/AIDS or AIDS-defining illnesses. Case 3. Patient is a 45-year-old woman who was referred to me by a rheumatologist for a new diagnosis of HIV in December 2015. Okay, well, I would say this is a successful story, but it had so many lessons in it. And that is why I presented it, just because we learn the most from our mistakes. So she was heterosexual in a monogamous relationship with a current boyfriend. He was tested and he was negative. She reported history of chronic complaints that first started in 2002. And when I asked her, how do you think you got this? She said that she had a history of a rape in 2002. And at that time, she was in Miami and she was tested for HIV and she came back negative. But the surveillance testing at 0, 3, and 6 months, she never went back. She did not mention that incident to anyone, which is very common in our culture also. and after that did not have any surveillance testing. So she presented to the urgent care, and she told me that a few weeks later, she went to the urgent care with a fevers and a rash. And this is, looking back, it looks like this was her primary HIV infection, and she was diagnosed with infectious mononucleosis, secondary to EBV.
Dr. Abbas?
Yes. Are we running out of time?
Sorry, just as a reminder, we will try to limit each presentation from 15 to 20 minutes, and you have another 3 minutes to wind up, please.
Okay, got it. Okay. So I think what happened with her is she went and got a lymph node biopsy. She had a colonoscopy. She had 4 episodes of shingles, and nobody could pick it up. And finally, when she saw her PCP, he did a CBC, which showed leukopenia and thrombocytopenia, sent her to a hematologist oncologist who gave her steroids and said, your leukopenia and thrombocytopenia has come up. Let me send you to a rheumatologist. And then the rheumatologist checked her for HIV. Her CD4 count was 7 and her viral load was 5 million. So we did the full workup. This is the initial diagnostic workup. We started her on Biktarvy, which is Vistegrivir, emtricitabine, and tenofovir. She became undetectable in 6 months, and last CD4 was 553. She continues to do well. I think I'll rest my case here.
Thank you. It was wonderful. Yes, I mean, I think it sometimes kind of presentation gets so interesting. We want to continue, and each of these presentations can be an hour presentation itself.
That's true.
So I think I'm being reminded that presenters have 10 minutes from the rest of presenters, just so we can, for our audience, as a respect to them, we can try to finish within an hour. So we are blessed to have Dr. Saima Abbas. She is our next presenter. She graduated from Army Medical College in 1999, and currently she is assistant professor and head of department of infectious diseases at Pakistan Institute of Medical Sciences, commonly known as PIMS in Islamabad. She is currently working as a Deputy National Coordinator for Tuberculosis at Common Management Unit, and she is also in charge of HIV Center and Isolation Ward. And she is also a focal person for dengue, polio, malaria, HIV, AIDS, and COVID. One very unique purpose of all those webinars is to share experience and also learn from each other. Just like Dr. Abbas presented her experience and her cases from United States, Dr. Akhtar is going to be sharing her experience from Pakistan. So her topic of presentation today is clinical presentation of HIV patients in Pakistan. Dr. Akhtar, if you could kindly take over, please.
Yeah, thank you very much for a very nice introduction. And I'm also very much thankful to APPNA-MERIT for giving this opportunity for Pakistani physicians to share their experience. And I think it's a good forum to disseminate the knowledge among our colleagues and those who are working abroad and in our country as well. So I will start my presentation by just recalling a case of a young boy who presented to me a few years ago. He was just a 13-year-old boy, and he was referred.
Would you like to share your screen, or you're okay without sharing?
Yeah, I will start with my presentation after sharing this case.
Okay.
And yeah, so he was just a 13-year-old boy. He presented to my clinic a few years ago. And he was basically referred from Jalalpur Jatta. And you remember that this is an area from Gujarat where we had an outbreak of HIV. And basically this young boy had multiple issues. Like 4 years ago, he was very much all right. And he started ending up with multiple opportunistic infections and recurrent fever, diarrhea, oral candidiasis, and all that. And he continued to lose his weight. So the family did not know that what was happening with the child actually. They kept on taking the patient to, multiple doctors, but the diagnosis was not made. So basically, the problem with the child was that he belonged to an area where there was an unnecessary use of IV antibiotics and IV fluids for minor illnesses. So he ended up with having HIV infection. So once the child presented to us, he was already in an advanced stage of HIV, and he was basically having AIDS, and he was having AIDS wasting syndrome. He was so much emaciated, and at the same time, he was also having disseminated tuberculosis. So I was just recalling this case because, most of the people in Pakistan, they didn't know that where to go for the diagnosis and from where to get HIV treatment as well. So this was a dilemma. And once he ended up at our hospital, he was already so much sick and emaciated and having AIDS wasting syndrome that even with the start of treatment, we could not, make him survive. So this was a very heartbreaking story, because nobody was positive in his family. Her mother was negative, father was negative, siblings were negative, but he was the only unlucky child who had this disease. So there were many more cases like this who were having this problem, and they didn't know what to do and where to go. So this was just to start my presentation with you. So I will be sharing my slides with you. Kindly let me know if you can see.
Okay.
Yeah, the slides. Okay. So
yes, we can see it now.
Visible. So
yes.
I will be starting with my first case. I think the slide is not moving. Let me see. Okay, can you see the slides, please?
Yes, we can. Yeah.
Yeah. Okay. So my first case is a 45-year-old male who presented in outpatient clinic with severe odynophagia for 1 month, and he also had progressive generalized weakness, frequent loose stools, and undocumented weight loss over the last 4 months. He was recently deported from Saudi Arabia due to a positive HIV test, but he denied any history of sexual contact or IV drug abuse. If we just go through these presenting complaints, we can see that all of these indicate towards some chronic illness. And these are all pointing out that patient is probably having some sort of immune deficiency, which was not diagnosed till the HIV test was performed. So on examination, he was a man of thin build. He was afebrile with normal blood pressure. Oral examination showed creamy white patches all over in oral cavity, palate, and tonsils. Rest of the systemic examination was unremarkable. So just to share with this, slide, I just want to highlight the thing that most of the time we come across such cases in our outpatient clinic, and it's not just the HIV with which patient can present with oral candidiasis, but we must think that if such kind of presentation is there, we should check HIV status. And this is how we come across the newly diagnosed cases. So you can see from this slide that this is so much extensive involvement of the oral cavity. It is just extending, beyond the oral cavity and involving the esophagus and the GI tract as well. So his rapid test was, repeated, and it was found to be positive. This patient was found to have leukopenia, lymphocytopenia, and rest of the workup for, other sexually transmitted diseases was also done. Syphilis serology was negative. Hepatitis B and C was negative. Chest X-ray, ultrasound, abdomen was absolutely normal, and his CD4 count was 249. I want to highlight over here that CD4 count has got a lot of correlation with the presence or absence of opportunistic infections. So if the patient is having a very low CD4 count, some of the infections are very common. Like you can see that patient can present with disseminated Mycobacterium avium infection. Patient can have histoplasmosis, CMV retinitis, and even this, CNS lymphomas and certain kind of malignancies are very common. As the CD4 count goes up, some other opportunistic infections are common, as Dr. Saima has already mentioned in her presentation. The patient can present with pneumocystis, patient can have disseminated, fungal infection, toxoplasmosis, cryptococcosis, histoplasmosis. And similarly, there are some other opportunistic infection, even when the CD4 count is on the higher side, like as tuberculosis is common if the CD4 count even is more than 500. Patient can have, herpes infection, herpes zoster, disseminated shingles, and patient can have hairy leukoplakia or Kaposi sarcoma as well. So CD4 count has, a relationship with the presence or absence of opportunistic infection. So very low CD4 count, severe opportunistic infection, and if the CD4 count goes on the higher side, you can see less severe and less disseminated infections. So this patient also underwent endoscopy, and this showed classical diffuse raised plaques that characteristically could be removed from the mucosa by the endoscope, and the biopsy yielded yeast and pseudohyphae of Candida albicans. So this is the endoscopic appearance of the Candida esophagitis. This patient was treated with IV fluconazole initially. It was followed by oral treatment, and once the patient was able to tolerate, and patient after that, once he improved, he was started on ARVs. At that time in Pakistan, we used to have this tenofovir, lamivudine, and efavirenz as a combination of therapy, and so the patient was put on this treatment. Right now, we have different options and new treatment regimens are available. But the patient responded to this treatment very well. My second case is a 32-year-old male who presented with bilateral painless progressive visual loss over last 1.5 months. He also had history of poor appetite, progressive weight loss, and recurrent diarrhea and abdominal pain over the last 6 months. He was businessman by profession, and he used to be a frequent traveler, but he denied any history of extramarital relations. So basically, this patient was seen by an ophthalmologist and was referred to our clinic. And at that time, the ophthalmologist raised the suspicion of CMV retinitis. And these are the pictures of his retina, which I wanted to share with all of you. That these are very classical presentation of CMV retinitis. Even without doing a test of an ophthalmologist who is very much familiar with these findings, can have a suspicion that this is most likely CMV retinitis. Although there is a differential diagnosis of eye involvement in HIV/AIDS patient, but once the patient presents with painless involvement and progressive and gradual visual loss in both the eyes, the most likely diagnosis is CMV. In this slide, you can see that this patient is having a lot of exudate, and this is a classical pizza pie appearance in which there are so many perivascular hemorrhages and cotton wool exudates as well. In the second slide, you can see a lot of exudates, and here you can also see that there are a lot of perivascular hemorrhages, which is a hallmark of CMV retinitis. Again, here you can see that we also call it as a brush fire appearance. It's just mentioning that patient is having a lot of perivascular hemorrhages, which is a classical feature of CMV retinitis. So this patient had a CD4 count of just 22. His ALT was also on the higher side. He had leukopenia, anemia, and thrombocytopenia, which probably indicates that this patient not only had CMV retinitis, but there was also systemic involvement. This patient's CT scan abdomen was also performed because he had the history of diarrhea as well, and it showed diffuse colonic thickening. And colonoscopy and biopsy could not be performed because the patient was so much sick that he was not able to, tolerate this procedure. He was started with IV fluids and IV ganciclovir, but unfortunately, this patient passed away. So just to mention over here that sometimes the patient do present with ophthalmologists with some of the features, and they end up with having this diagnosis of HIV/AIDS. I would also like to mention over here that in Pakistan, we have a lot of constraints in, not only for the diagnosis of the patients, but we also have a lot of problems with the availability of the treatment options for such kind of patient. Like we do not have, for life-threatening or side-threatening infections, we may not be having the easy availability of intravitreal injections. We do not have foscarnet and all that. So even ganciclovir and ganciclovir is not easily available. So we have to face a lot of challenges while managing such kind of patients. My third case is a 53-year-old male who presented from one of the cities from Punjab in 2018, and he was already a known case of HIV. He had history of herpes zoster along left C4 dermatobe a year ago, and he presented with exertional dyspnea for 3 months and was brought in a wheelchair. There was actually no history of fever, cough, or chest pain. His O2 saturation with pulse oximeter in the clinic was found to be 80%. Vital signs were normal. He was afebrile. His chest examination was unremarkable, and his systemic examination was also normal. He was hospitalized, and it was assumed that this patient is having, pneumocystis jirovecii pneumonia. I would like to mention over here that in Pakistan, we do not have much of the diagnostic facilities, and we do have so much issues for involvement of other departments as well. Like we do not have much of the facilities of bronchoscopy available so that we get, bronchoalveolar lavage because of so many issues. Maybe there is some hesitancy from the physician's part as well. And once they know that this patient is HIV positive, we do have such kind of problems. So most of the time for PCP pneumonia, if we have a clinical suspicion on the basis of history and all that, we just start an empirical treatment for, and most of the patients, they do respond. This patient was also started on cotrimoxazole along with steroids because he was hypoxemic. And meanwhile, he was worked up for his respiratory distress. So this is the chest X-ray of this case. And since we were just assuming that this patient is a case of PCP pneumonia, I would like to mention over here that for PCP, sometimes you may not be having very classical features of PCP, because in PCP, you have classical perihilar involvement, and the apices and the lower ends of the X-rays are absolutely normal. But sometimes you do come across with fairly normal chest X-ray, even when the patient is having PCP pneumonia. Sometimes atypical presentation do occur, like in the form of presence of, atypical infiltrates, like you can see in this case. So this patient's blood counts and all that was normal, and his LDH level was 284. Beta D glucan was 397 with a cutoff value of 60. ABG showed hypoxemia, and his saturation was found to be 74 in another occasion, and the CD4 count was just 84. So I would like to mention over here that sometimes if we do not have the facility of bronchoscopy and all that, we do get, indirect testings, like we can do an LDH, because LDH is a marker which can tell us that this patient is having probably PCP. And sometimes we do, monitor the progress of the disease, whether the patient is improving or not improving. Just we see the improvement in the LDH levels or just decline in the LDH levels. Beta D glucan is also it's not very easily available. It's very costly test, but if the patients sometimes are able to afford it, because in Pakistan, most of the investigations, they are not supported by the government. The patients, they have to pay from their pocket. So this test was performed by the patient himself, and obviously was prescribed by us, and it showed that this level was very, very, very high. And so we just assumed that this patient is having, pneumocystis pneumonia. Later on, yeah.
Sorry, we have 3 minutes to go.
Okay, so bronchoscopy showed pneumocystis jirovecii pneumonia, and his TB workup was negative. And this patient was treated initially on Septron, but unluckily he did not respond to Septron treatment. And later on, he was started on the alternative treatment with clindamycin and primaquine, because this is the only alternative therapy available in Pakistan with us, and patient responded very well. I would just be sharing another case in very fairly quickly, that there was another case who initially presented with tuberculosis, and she responded well to the treatment with anti-tuberculous therapy, but she gradually became severely short of breath, and later on was found to be PCP pneumonia. So PCP pneumonia is fairly common, and TB and PCP pneumonia sometimes they do appear concomitantly. And here you can see that this is the chest X-ray of PCP pneumonia, where there is a diffuse haziness all over the chest X-ray. And just taking the opportunity of this presentation, I would just like to show you 2 more slides before ending my presentation. This is another case who presented with very low CD4 count. He was diagnosed case of HIV, and here you can see that multiple raised and slightly purplish lesion on the skin, and this patient was having molluscum contagiosum. This is another presentation among especially all those patients who are having, sexual partners, male sexual partners, those who are MSM, although there is a large list of differential diagnoses. And this is my last slide, which is just showing that multiple raised purplish cutaneous lesion, and this is a presentation of Kaposi sarcoma, which is another form of advanced AIDS. And this patient was basically treated not only on ARV, but was also given chemotherapy for the treatment of Kaposi sarcoma. So I will be ending my presentation over here. Thank you so much.
Thank you very much, Dr. Akhtar, finishing on time. And I think if you could stay here for question and answer session once we are done with all the presentations.
Sure.
Our next presentation is by Dr. Faisal Mahmood. He is a graduate from Aga Khan University Hospital, Karachi. He did his internal medicine residency from University of Illinois in Chicago, and he completed his infectious disease fellowship from University of Rochester, New York in 2004. Currently, he is Associate Professor of Infectious Diseases at the Department of Medicine, and he is also Section Head for Infectious Diseases and Program Director for Adult Infectious Diseases Fellowship Program at Aga Khan University. He had taken quite a few projects in collaboration with the private sector and public sector with the government help, and his topic today is HIV treatment availability in Pakistan. It'd be interesting to see and hear his experience. Dr. Mahmood?
Assalamu alaikum. Can you hear me?
Yes, Dr. Mahmood, we can hear you. And
thank you so much for the invitation and for the kind introduction. So actually, I don't have any slides, and I'm going to keep this brief so then we have more time for question and answers afterwards. And my topic was fairly straightforward, as in what is the availability of ART in Pakistan. And I think the couple of questions that were asked of me was, how do people access care in Pakistan? Do they have to pay for it? Is it private? Is it public? And if there's a private practitioner who has an HIV patient, what do they do? Where do they send this patient? So a couple of ground realities, I guess, in Pakistan. The first is that HIV therapy is not available sort of for private practice. So HIV therapy is only sort of dispensed at ART centers, which are across the country. We have about 49 ART centers. There are 4 in KPK, 2 in Balochistan, there are 2 in the federal areas. There are 25 in Punjab, and the rest are in Sindh, about 15-ish in Sindh. These ART centers are run by the provincial programs, and they're manned by an ART physician. Usually they have a data entry operator, because everything that we do with the HIV patients is uploaded onto a central MIS. And then on top of this, we have sort of counselors in these areas. What's important is that all HIV medication in Pakistan at this point is free. So you do not need to pay for your HIV treatment in Pakistan. And this is provided through the Global Fund. And hence, medications are completely free. So even though there's not accessibility to these medications by private practitioners, people who have HIV don't have to pay for it. Similarly, some of the basic blood work is free also. So that would be things like viral load. In most centers, the CD4 sort of CD4 counts, those are also free of cost. However, having said this, there are some labs which patients need to pay for. So just like Dr. Naseem was mentioning, if you have blood work, specialized labs like for PCP, so centers have to pay for that. But keep in mind that a lot of these centers are in tertiary care and government hospitals, and so care over there is subsidized or even free in some cases. How do patients arrive at these centers? So there are actually 2 or 3 pathways. They can come through the CBOs, which are so a step back. So the funding for Global Fund comes to sort of the public sector, but also to the private partners, which are often your people who take care of key populations. So an example would be, for example, Nayi Zindagi, which is an NGO which works with IV drug users. So if they identify a patient, they will refer this patient to sort of one of the centers. And the way the system is now set up is that they enter that into the patient in their sort of system, and that system is linked to the ART center. So that so that we can link people to care more easily. If you're a private practitioner and you have a patient you want to transfer, then you can simply go onto the website, and it has a list of all of the centers close by, and you can link the patients to any of the centers over there. So just send the patient there, and we will register and put them on therapy. So all that's well and good, but just a couple of maybe a minute or 2 on what the problems with this whole process is and where are we heading from here. So one big problem is that for a big country like Pakistan, 49 centers is not a whole lot, as you can imagine. So if you have people living in villages, if you have people living far away, coming to an ART center is not very easy, and that leads to sort of delays in getting care or additional costs. So even though the cost is free of the medication, somebody who has to sort of go hundreds of miles to the center, I mean, there's a cost associated with traveling to these places. The other problem is linking to care. So a lot of IV drug users will get lost to follow-up because of this. And then the third problem is that a lot of these centers are not manned by ID physicians, and they're manned by people who train for HIV. But because when there is a turnover, you may have people who are not as well equipped in treating these patients. And where is this heading now? So a couple of changes that are occurring, and some of this has happened in Punjab already. Sindh is also going to be doing the same, which may be good or bad. Which is, instead of doing a vertical program where you have, your for example, Sindh's control program taking care of their centers, this is going to become horizontal across sort of all of the other hospitals. So, which means that accessibility to care would be much easier, but maintaining sort of quality of care may be a little difficult. The other thing that we're working on is something called DSD, which is the differentiated service delivery model, where what happens is a person comes to an ART center, they get registered, they get put on therapy, and once it's stable, then they can just go to their local sort of BHU, basic health unit, and pick up the medicines from there. And over there, they just get a very simple sort of a quick screen, make sure everything's okay, and then they just keep taking the medicines, and they don't have to come all the way to the ART center to get treatment. So these are some of the things that are in the pipeline. And once and we don't know how soon this is going to get implemented. And then obviously there's a big sort of talk about or push towards moving towards primary healthcare. So and universal health coverage because of this. So this is sort of just a quick rundown of the questions, and then we can do some question answers for particulars after this. Thank you.
Thank you very much, Dr. Mahmood. It was very entertaining and kind of very teaching for all of us kind of sitting abroad, and good to know that things are moving forward, and it's also good to know that kind of database is being maintained, which I think can definitely help to organize the care. And our next presentation is by Dr. Soumya Iqtidar. She is a fellow in medicine, and she is working as associate professor of medicine at King Edward Medical University. Apologies. She completed her postgraduate training in internal medicine in 2010, and she is part of many advisory boards. She is a master trainer for dengue infection, and she is also WHO and Government of Punjab's speaker on that topic. She is chairperson and dengue expert advisory group and first general secretary of Pakistan Society of Internal Medicine, commonly known as PMIS. She has numerous publications to her credit, and she has also contributed to three chapters in Kumar and Clark. I remember that book from my days in undergraduate when we used to read that in medical school. And her areas of interest include cardiometabolic medicine and infectious disease. Her topic today is HIV continuum of care for primary care from a primary care point of view. It'd be interesting how it goes from those ART centers to primary care. Dr. Iqtidar, it's all up to you.
Okay, thank you very much, Dr. Muzammil. So just a little correction, it's Pakistan Society of Internal Medicine, PSIM. So this is a Society of Physicians of Pakistan. Okay, so I've been given a task to talk about the primary care and preventive strategies which we as general medicine or internal medicine fellows come across. So, HIV used to be a rare disease a few decades back in Pakistan, and you would hardly see any patient in our outpatient clinical practice or even in hospitalized where there would be a big alarm when an HIV case comes. But for the past few years, HIV admissions and as well as the HIV reporting to your outpatient or in your private practice is no more a reality. And people do come in usually with a positive test. And I would like to mention here that there are few categories of patients that come to you more often. One are the people who get their medical checkup done for some job interview or whether they have to travel abroad. So they just go through the test and for the first time they get to know that they are HIV positive. Sometimes when they go to a blood center to donate blood, then they're screened, then they get to know that they are HIV positive. The third type are people who get it after some exposure, or if there is something mentionable in the history and they get their HIV test and they turn out to be positive. And then there are some typical groups that we come across, which includes the transgenders and IV drug abusers and sexual workers. So these are main few categories with which patients come to an internal medicine specialist. Now, these are the people who know that they have HIV because they have their tests done. But there are a lot of people who are still not diagnosed, but they come with a suspicion of HIV to your clinic. And for the information of family physicians who are attending this seminar webinar today, I would like to say that whenever you have an unexplained weight loss, if you have lymph nodes, if you have rash, recurrent oral ulcers, gingivitis, repeated opportunistic infections, especially pneumonia, dermatological unexplained features, or chronic diarrhea, always go for a testing because there is no other way to diagnose. So testing is a must. If you have a high clinical index of suspicion, always go for a testing. The problem with HIV testing here in Pakistan is that still there is a lot of stigma attached by getting the test and advising the test. Whenever you tell patient or write on the prescription to get an HIV test, the first reaction is, no, it's not that. So how do you know it's not that? Unless until you don't check, you can't say it's not that. First thing that I would like to emphasize for the family physicians or the internal medicine specialists is go for testing whenever you have index of suspicion. Whenever there's something in the history which points towards a diagnosis, if something in the examination which points towards an HIV diagnosis, or if you have a high clinical index of suspicion, please go for the testing. There's no harm in testing, and convince your patient that it's for their betterment. The number 2 point is that when a patient comes to a general medicine or internal medicine or a family physician, they think that they are not specialists. So whenever they come across HIV as a positive test, they would like to see an infectious disease specialist. But there are many things which can be managed at the primary care level, and you don't need to see an infectious disease specialist for it. And there are some pearls that I would like to share with the physicians. Number 1, honestly assess your ability to care for that patient. You think that you are able to cater to the needs of that patient, you can advise testing to the patients, you are capable of handling, please do go ahead. But if you think you are not trained enough to treat these patients, please refer to an infectious disease specialist. Number 2, order appropriate labs and from a reliable lab. So we know that screening tests is sometimes done by the patients, but we need to have a CD4 count or viral load, although we know that we need to start the ART even if the CD4 count is not low. So the ordering of appropriate lab tests is also very important, and doing it as soon as possible is the need of the hour. Then the third and the most important thing that I think being a primary care physician is to begin counseling of the patient. First, don't give ambiguous statements that this might be or this might not be, and we need to check it and try another lab. Be very clear that you have HIV, because it is very difficult for the patients to understand this and take this that they have HIV, but you need to be firm yet polite and make them understand that you have HIV. And secondly, highlight the fact that HIV is not a death sentence, because the next question that they ask is, I'm going to have AIDS, I'm going to die, how much days are left in my life? Because there's so much fear and scare related to this diagnosis. So these are the few things. Then in the examination, please look for the signs which point towards diagnosis. Take a complete history in privacy, maintaining confidentiality of the patient. And third, fourth, fifth, and most important, I think, which already Dr. Faisal pointed out, that the ART is not available in the private sector. So we have to refer to referral clinics of HIV treatment, which are the ART centers in the public sector hospital. In Punjab, we have Punjab AIDS Control Program. I work in Lahore in King Edward Medical University, so I'm more aware of the situation of Punjab, in which the Punjab AIDS Control Program, it's running with the primary and secondary healthcare department, government of Punjab, and this operates under the umbrella of health department. So the objective of this department is to prevent HIV transmission to population through awareness campaigns, and they have some diagnostic facilities and treatment facilities which are all free of cost in the designated centers. There are many designated centers in Punjab province. There are, I think, 36 districts. We are trying to establish in all 36 districts, but at the moment, there are 16 ART centers, and there are 4 or 5 centers in bigger cities like Lahore, and 2 centers in the smaller areas. So what for services they provide, all the physicians, they need to register the patients that they see, even in their private practice, to these ART clinics, because they need to get treatment and medication is available free of cost, but only in the private setup. Some of the medications is available in the Shaukat Khanum Hospital, which is a private sector hospital, but infectious disease consultant sitting over there, and they have a stock. So sometimes it is available over there, but majorly it is not available in the pharmacies and market.
Dr.
So
sorry for interrupting. I just want to point out to one fact for our audience. There are many questions in chat section. It is going to be a little bit difficult to keep track of all those questions. If our audience can type that question in question answer section, it'd be easier for us, for moderator and for panel to answer those questions. So there are a few comments which don't need to be answered in chat, but there are also few questions, a lot of questions. If all those people can simply ask those questions in question answer section, it's exactly at same spot just before chat. Appreciate. Dr. Iqtidar, sorry, you can continue.
Thank you. So some of the services that are provided in the ART centers, which you can refer your patients to, one is the voluntary confidential counseling and testing, which is called VCCT. The other one is prevention of parent to child transmission, because you know that many of the patients, they are tested during pregnancy and there is a risk of transmission from mother to the child. So we have a PPTCT, which is prevention of parent to child transmission. And there are separate pediatric HIV treatment centers as well. And there are diagnostic facilities available in all these centers regarding testing of HIV, along with other diseases like Hep B, C, syphilis. And these are all free of cost. The treatment and medication and follow-up is maintained in a digitalized form, and it is in a central database of HIV. I am also trying to talk to UNAIDS to provide an application or a software to the private practitioners as well. There are people who do not want to go to a public sector hospital for getting treatment, and they do not want to get exposed or registered in the system. So if there is a way to confidentiality is maintained with the doctor whom they trust with their treatment and provide them treatment, so that we can order to the department to give this much amount of medication for this particular patient by giving them an anonymous number or an MR number. So we are also trying to do that in order to facilitate the patients in the private sector hospital. So I think my key message would be that HIV is to be treated at every stage. There is, the WHO guidelines say that there is no role of staging or CD4 count. Now everybody has to be treated. Secondly, a lot of stress should be given on the post-exposure prophylaxis. It should be given as soon as possible. Within 72 hours, a lot of medical students come to me, a lot of surgeons come to me because they have an accidental prick and they don't know where to go. Sometimes there is a history of sexual contact and people come and say that they want to get post-exposure prophylaxis. So we need to refer them to an ART center, which provides post-exposure prophylaxis. It's a bit longer for 28 days, but we need to tell them that it minimizes their chances of getting into the serious problem. So I think this is from the primary care physician's perspective, and we should all upgrade our knowledge with the constant CMEs like these and interact with the infectious disease specialists as well, so that we can bridge the gap between a primary care, a general medicine, internal medicine specialist, and a super specialty like infectious diseases or HIV consultancy to help bring down the burden of HIV in our community. Thank you.
Thank you very much, Dr. Iqtidar. It was very entertaining and very interesting and very kind of informative. Appreciate. So we have a lot of questions from our audience. As I said, if they can be typed in question answer section, it will help us to keep the track. If you have already typed your question in chat section, please bring it to question answer section. So I can probably start with the question before we get the questions organized by Dr. Gilani and rest of our team. First question, probably I can start with Dr. Mahmood, is there a way government can incentivize the removal of those used needles? I see many times people, not only in Pakistan, but also even abroad, people in plastic business, you know, they be collecting plastics and selling it on weight basis or whatnot, just to earn their living. Can that thing be similarly done for, especially for used needles, so they don't get reused or get in wrong hands?
So there are actually two ways of doing this. The first is that there are needle exchange programs in place as part of risk reduction or harm reduction programs where IDUs can go and give in their old needles and get a fresh needle in. They work well, but there are ways of loopholes which IDUs find out. So for example, they will give a needle in and sell the new needle and still use their old needle. So that happens. The other thing is there is legislation now coming on where that hospitals will be mandated to use self-destructing needles which self-destruct. So then it sort of becomes a moot point in terms of these needles being able to be reused again.
Okay, wonderful. My next question was needle exchange program, but you already answered that. You know, that I did not know. I was going to ask you if there are any programs like harm reduction programs which do exist. I'm glad. And is it easily available in all cities, or it's very limited and bigger cities only?
No, yeah, so they are available, and the way it works is the NGOs will link the IDUs to the needle exchange program. So since our epidemic it was and is probably driven a lot by the injection drug users. So there are a lot of NGOs working with it, with these groups, and they're the ones who link it with the needle exchange programs.
Good to know. And next question, maybe we can ask Dr. Iqtidar. Somebody had asked in chat section, I think, yes, it's good to know that there are structured centers where ART treatment is provided and it's free of cost. But as you pointed out, there are going to be many people who probably are going to be contacting either their general practitioner or they are going to be becoming their consultant in their catchment area rather than going to that public sector where they may not feel comfortable. There may be a lot of people sitting in the waiting room and kind of there are people with kind of each financial status, you know, where they may not feel comfortable in the same waiting room or with the other people where there may be stigma attached to it. So it, in one way, it does make things a little bit easier because the services which general practitioners are supposed to provide are limited to diagnosis and probably pointing out and diagnosis of complications and pointing towards the right people. So a question was, is there a set protocol for diagnostic tests, and what are the test kind of that protocol if people can get access in general practice or internal medicine or even other specialists? I think your microphone is off.
Thank you. Thank you. There are certain tests that we need to do. We need to confirm by ELISA, CD4 count has to be done, and PCR viral load. And we initially do the baseline investigations. He has very rightly pointed out that majority of the people who come to a private clinic would not like to go to an ART center in a public sector hospital. That's why I said that I had already talked to UNAIDS and Punjab AIDS Control Program because I work in Punjab. If we could find a mechanism and dedicate few centers in the private sector where they can follow up and they can register few doctors who are trained to treat the HIV disease. So it's in the process. And secondly, in private sector hospitals, I read in the chat box, somebody mentioned about Aga Khan University Hospital and Indus Hospital providing the services in Sindh province, but in Punjab, it is only present at the moment at Chaukat Khana Memorial Cancer Hospital.
I see. I think question was, can, say, a Society of Internal Medicine come up with just a single page protocol or a guideline for people?
That's a great suggestion. I think we regularly publish our guidelines in our journal, which is Journal of Pakistan Society of Internal Medicine. Last time we published about hypertension. This time we are publishing about COVID-19. I will make sure that in the coming issues we publish about HIV too.
Thank you. Because I think it makes, I know a general practitioner can be very busy sometimes, and they may not have time to refresh their knowledge that easily. But I think if there's just a single page and just it's a click system, it might help. It may streamline things on their point, and it probably improve services. And as on the same lines, I think from US, probably with Dr. Gilani had already started this, we can come up with people in ID in Pakistan as well as internal medicine and in US to come up with a few lectures, kind of a separate series of HIV lectures, just to kind of refresh practitioners, general practitioners and other specialists on diagnosis and management, identification, or just picking up the complications and management. I think Dr. Saud had asked next question. I will let Dr. Naseem Akhtar, I think, answer. Unfortunately, we have lost Dr. Abbas. She had to leave. So the question was about HIV treatment in pregnant women and breastfeeding women. And I think Dr. Saud has pointed out there was also an article in newspaper. I'm not aware of that, but if somebody knows, if they can explain. Dr. Akhtar, if you could kindly answer the question.
Yeah, thank you very much. The HIV treatment is available for all in Pakistan, and as far as the pregnant ladies are concerned, we are providing treatment to them as well, obviously. And as you know that HIV transmission during pregnancy and then during breastfeeding and even during delivery is possible. And we start treatment as soon as the patient is found to be HIV positive during pregnancy. We start ARV treatment on them. And we continue the treatment. And obviously, as you know, that the treatment is lifelong, we have to continue treatment for all the stages, and it is lifelong and it has to be continued. And as far as the breastfeeding is concerned, in Pakistan, we allow our Pakistani ladies to continue breastfeeding while they are on ART, because while on ART, the risk of transmission becomes very low. And since we do have a lot of constraints, and because of various other issues, like because of various nutritional issues for the babies as well, because of poor socioeconomic status, we advise the ladies to continue breastfeeding their babies while they are on ART.
I just wanted to add that we can also give profile access to the newborns if they are born to a mother who's a known case of HIV.
I see. And similarly, as far as prophylaxis is concerned, Dr. Iqtidar, maybe we can continue with you. If somebody gets needle stick injury there, I'm sure there are going to be places where people, especially healthcare workers, can report to or can ask for help for testing and probably prophylactic treatment if the person whose needle originally, he is HIV positive. Am I right?
Yeah, we do give post-exposure prophylaxis to the people who have exposed by needle stick injury, and it is to be given for 4 weeks. And it minimizes the risk of transmission. If the status is known, we have to definitely give, but if the status is unknown, still we start, and then we follow these patients over the period of time.
Okay, thank you. And I think another question was asked by Dr. Azam Khan. Name few NGOs where patients can be referred for ART centers. I'm not sure if question is NGOs who can help transport patient or can connect patients with ART centers. I'm not sure if Dr. Mahmood wants to take this question.
Yeah. So I think it depends on which key population you're talking about. So so as you know, we have 4 main key populations over here. One are IV drug users, the other are MSM. Then we have the female sex workers, and then finally the transgender. So each of these have their own sort of NGO groups that are working with them. So I guess would need more detail on which key population you're talking about. If it's somebody in the general sort of domain of the general population, so maybe like somebody from who got it from blood transfusion. So there are currently no NGOs working in that domain.
If I can answer this question, I have the names of few NGOs which are working. These are the community-based prevention services that we are offering in Punjab and all over in the Pakistan. There is a Diricha Male Health Society, there is Sati Foundation, there's a Khaja Sira Society, there is Wasib Samro Society, we have Zali Welfare Society, Hamraz Male Health Society in Karachi, Milli. They are all registered with the AIDS control program and they help facilitate the patients. There's also Active Alliance Foundation in Multan. And in Larkana, we have Ghazi Social Welfare Association. In Karachi, we have Women Health Welfare Organization. There's Baham Foundation in Lahore and Organizing Action Towards Humanity in Bahawalpur. These are some of the major associations which are working at facilitating patients of HIV. They're acting both on the awareness side, preventive sides, and facilitating the patients in getting the ART.
Wonderful. Dr. Iqtidar, I think this was a very detailed list, which people may not remember.
Yeah, you can go to the Punjab AIDS Control Program site and you can find the list over there under the heading CBO.
I would also suggest if we can, we have APPNA-MERIT YouTube channel. In the comment section, we will add that list of all those organizations. So if somebody is also watching later on, at least they will have a reference. And I may request you to provide me that list or at least the link where these are so we can share it there. Thank you. And another question, I am going to leave it open to panel so you can pick who wants to answer. Dr. Hassan is asking if the pregnant women are universally tested for HIV.
Yes, pregnant women are universally tested for HIV, and at whatever stage of pregnancy, if they are diagnosed with HIV, they are started on treatment.
I can mention over here, so pregnant women are not universally tested for HIV. It depends which where you are. So in Sindh, where you have in rural Sindh especially, where care is provided by PPHI, which is a private partner for health delivery. Over there, all pregnant women are tested for HIV. But a lot of people in, for example, the biggest cities like Karachi, if they go to a private practitioner, they're not checked for HIV as a routine.
Okay. This question may be relevant to Dr. Naseem or Dr. Mahmood. Is there any suggestion or kind of any proposal of extending ART centers in a mobile clinic model just to increase the reach?
I think Dr. Bushra Jamil is with us in the panel, and she is right now currently heading CMU, that is for AIDS, TB, and malaria. I think she can answer this question. Over to Dr. Bushra.
Dr. Jamil.
Mobile clinics.
Yes.
First of all, we need to strengthen our basic healthcare units and expand HIV services to all basic healthcare units in the country. Next is the possibility of offering mobile healthcare units. And recently we were engaged in discussions with many CBOs, and we've listened to their issues and problems, and we may be offering or developing some kind of a mobile unit which would be multi-purpose, not just providing diagnostic services, but maybe addressing infection control and so on. So this is all under discussion, but having mobile units is not our primary objective. Our primary objective is to strengthen basic healthcare, basic and then secondary healthcare, so that the facilities are available widely, and maybe hand over the responsibility of providing HIV care to family physicians, and not just restricted to infectious diseases physicians, because
Sorry, Dr. Jamil, we are losing you. It's a poor line. Okay, maybe we can direct our next question. Sorry, Dr. Mahmood, you want to answer? No, sorry.
Sorry, may I just add one? I just want to add very quickly to what Patricia said, and I agree with her, what she said, but we have also tried mobile sort of ART, especially for IV drug users, and this has been a pilot project that has been done in the past. It's run into, I mean, depending on who you talk to, it was either very successful or a failure. So I mean, but it has been looked at and tried just for a certain number of population, a certain type of population.
Okay. No, thank you for answering this. Sorry, Dr. Jamil, we couldn't hear you, but hopefully your line be fixed. Okay, so our next question is coming from Dr. Saud Javed, a wonderful colleague and friend. He is questioning what's the compliance of patients with HIV medications, and if they are not compliant, what's the biggest reason? And what are implications of somebody who is not compliant? Can something be done? Sorry, these are three questions in one question, probably.
I think I can answer that, and anybody can answer from the panel as well. They can add to my answers. So the most important thing which we have noticed in our clinic is that the patients who are using, they are involved in IV drug abuse, they are the main reason for the loss to follow up. And once we start treatment at some other point in time, they again indulge themselves in the IV drug abuse, and so they basically stop treatment. And the second thing which we have noticed is that some of the patients who come from the very far off places, and sometimes they once they improve on the treatment, they think that they are all well and they don't need any more treatment. Sometimes there might be some issues with counseling and all that. That is a major second thing. And the third thing which we have noticed, that all those who are patients who are having very advanced disease, and those who are very, very sick, and they are having multiple opportunistic infections and all that, they do very bad. Once they start improving, they continue with the treatment, but if they do not improve, or they have a very slow recovery, sometimes we do have issues with the compliance. But in Pakistan, our major issue is IV drug abuse, where we have seen that the patient, they are not compliant to the treatment. I think Dr. Faisal can add to these points from his experience.
No, I agree with you. I have nothing more to add. Thank you.
Okay. Thank you. And also for audience, I just want to point out, we are going beyond our allocated time. And if you want to leave, we will not mind. But if our panel is willing to stay, we can probably answer all the questions, even if it means we may have to go for 1 hour, 45 minutes or so. I mean, we are already 1 hour and 24 minutes. So another 20 minutes, if it's okay with panel. Dr. Mahmood, is that okay? Dr. Naseem and Dr. Iqtidar?
Yes, please.
Thank you.
Thank you.
So, thank you.
Thank
Our next question is coming from Dr. Ayaz Ali Lagari. His question is, can ART and ATT be used in HIV patients together? I probably know the answer, and I assume ATT, he means anti-tuberculosis therapy, unless it's something for HIV patients. Question
I
was,
can answer. Yeah.
yes, please.
So
I think the question is regarding
Can I answer
start
that?
antiretroviral therapy for HIV patients.
Mhm.
Yeah. So all those patients who are having, TB infection, obviously, first of all, they are, diagnosed for TB and they are started on, anti-tuberculosis therapy. It depends on which sort of tuberculosis is that. For most of the patients, they have pulmonary tuberculosis or CNS tuberculosis, whether it is sensitive TB or drug-resistant TB. So all of these patients are started first on, anti-tuberculosis therapy. And at the same time, we also check for the CD4 count. So if the patient is having a very good CD4 count, then we can wait for at least 6 to 8 weeks before starting antiretroviral therapy. But if the patient is having advanced disease and the CD4 count is very low, say it is 50 or less than 50, then we start antiretroviral therapy earlier on, maybe within a period of 1 to 2 weeks, once the patient is able to tolerate both these drugs together. And then we have to see a lot of drug-drug interaction between antiretroviral therapy and the anti-TB drugs, and we have to see which kind of anti-TB or antiretroviral therapy is available over here, and we need to carefully see what are interaction and when to give some additional doses of ARV if they are needed. So it all depends on the clinical situation of the patient.
Thank you. Dr. Mahmood, you were going to add something?
No, Naseem caught it. But you just that we have to remember to do with both our first line and second line regimens, there are interactions that need to be looked at. So that's the most important thing to keep in mind.
Okay, Dr. Iqtidar?
Yeah, same. Just we start with the ATT and then we start with the AR antiretroviral therapy as well, and preferably within 8 weeks we should start the therapy.
Within 8 weeks, they should be on both therapies. Okay, and Dr. Gilani?
Yeah, I just want to add something here. Next week, our webinar is on hepatitis C and HIV, and the week after is HIV and TB. So please stay tuned and we will have a lot more discussion on these issues. So I have one question from all of you, if you know the answer. There was an article in a newspaper a few weeks ago about the children in remote villages of Sindh are dying because of non-availability of ART. My question is, almost all of you said that ART is free available in Pakistan. So is there any disconnect here between the providers of those children and these centers, or those doctors, they don't know where to go, where to get the free ART? I'm trying to understand this, so please explain if you have any idea on this. Thank you.
Maybe we can direct this question to Dr. Mahmood. He is based in Karachi, Sindh. Maybe he knows setting a little more and services a little bit more in Sindh.
So I shut my camera off. My bandwidth is a little low, if you can hear me. So the issue is, so the issue I think is more in terms of linkage to care. The ART center, keep in mind that this is Ratodero. So the ART center over there is relatively new, but of most of our ART centers in the country, this one is actually better equipped because a lot of resources and a lot of training have gone into it, both from UNAIDS, from UNICEF and WHO. But yes, linkage of care is an issue. And if somebody is positive, if a kid is positive, then linking to the center, keep in very, very low coverage for both vaccines, and also kids over there tend to be very malnourished to begin with. So the death rate in children is very high to begin with, and linking them to care and HIV sometimes they're least of the problem. And the bigger problem is the malnutrition and all the other things that go along with it. So part of it is linking to care and HIV, but they may not be dying of HIV disease, but for other challenges which we see in these sort of poorly served areas of the country.
Yeah.
Okay.
Thank you, Dr. Faisal. Actually, these are the issues I think we should be focusing on, these training of these providers, that these like ART are available, but they should be focusing on all these free sources as well as what are the other health issues. So the training in those areas, training of these providers is really important in my view. Thank you.
Okay. Yes. Next question is again another question from Dr. Javed. So Javed, he was asking, based on your information or data mining for HIV registry, what is a CD count for average patients, just to get an idea how successful our delivery model is? I don't know who will have more access and information about registry. Dr. Mahmood, I think you're.
So I can answer part of it. So I can't give you what our average CD4 count is, but I can tell you that the biggest problem over here is late diagnosis. So if you just look at, for example, the let's go back to Ratadero. A lot of the deaths that occur very early on after therapy started, which sort of speaks to the fact that when the CD4 is low, is reaching out and increasing our all the people who are infected with HIV. And as you may have already, in fact, I think you've already had the session with looking at our 90-90-90 goals. Struggle with our first goal, that is 90% of people who have HIV know their diagnosis. And that is where a lot of the resources are now currently going in trying to identify these folks before they they have full.
Okay. Unfortunately, Dr. Mahmood, it looks like, yes, your line is also somewhat poor. Maybe next question we can ask Dr. Akhtar or Dr. Iqtidar. Dr. Khalda Zaki is asking, insight for HIV among women in Pakistan, causes of contracting infection vary by does it vary by gender based on information and data you have?
Yeah, thank you very much. In Pakistan, we come across HIV among women, especially those who are spouses of positive cases. So this is the most common route. Although we do come across a very less number of women who contract the disease after they had some sort of blood transfusion during their cesarean section and all that, and very few cases were reported. Those who were exposed to injection usage, especially in those areas where the outbreak was there. So the most common route is basically from HIV positive spouses. And most of the ladies, they come with this infection and they are not very much aware of, disease transmission. And that is the reason that, because of poor education and lack of awareness, they contract the disease. And especially their husbands or their spouses, they are diagnosed with HIV very late in their presentation. So they already have advanced disease, and most of them, they die because of the infection. And during that period of time, they contract the disease while they are not on ART. So this is the scenario with our women in Pakistan.
I see. And another question by Dr. Fayaz, by Dr. Alisha is, I saw a HIV patient with complications who passed away. Now his wife comes to see him, who is 5 months pregnant, and he is having low-grade fever. Her HIV serology was negative at that stage. Is there any protocol with which this patient can be tested and her kind of diagnosis can be either excluded or anything specific? I think his question is probably during the phases of seroconversion or before full seroconversion.
Dr. Faisal, would you like to answer this or should I? I think
I can answer it.
Yeah, Dr. Faisal.
If you can hear me. And I think the key thing over here is to make sure that a reliable test was used when you say this is negative. So and that would be my first concern. That is this a false negative or true negative? Because a lot of private labs use tests which may not be which may have very low sensitivity and not be quality assured. So that would be the first thing I would recommend it to somebody like this.
Okay, thank you. I think we are coming towards end of our question, unless Dr. Gilani, you had seen any questions in the chat section.
No, I think that's it. If someone has a really important question, please write it in Q&A, but I don't see any other. Most of them are already answered. So Dr. Bushra Jamil, do you have any other question in your queue?
So I think this was a very useful session. All the presentations were excellent, and they're actually according to our objectives of creating awareness and engaging as many physicians as possible towards getting information on HIV care, because HIV is increasing in Pakistan, and it is our responsibility to make sure that everyone who comes in with possible infection gets the appropriate diagnostic tests and gets access to the treatment which is available free of cost. And I think now is the time to actually consider universal testing for pregnant women and for, in addition to other patients which we may suspect because of clinical features, but maybe we should go for universal testing of pregnant women now in the country. So thank you very much.
There is one question actually in the queue. This is about the pre-exposure prophylaxis to key population. So is there any guidance on this, or is there any protocol to give the
Yes, I can take this question because this has been under consideration to be part of the strategy of National AIDS Control Program through Global Fund. And this will be addressed in the next funding cycle. So this is under consideration and will be part of the strategy.
Okay. I had something in my mind when I was kind of going through with seeing Dr. Naseem Akhtar's presentation. To deport somebody just because he tested positive for any disease, it goes against the basic tenets of public health. That probably is going to simply delay the reporting of that thing. And by the time patient presents, many of them may be very advanced just due to the fear. Obviously, it's beyond our control, but I think we probably need to educate, at least at our diplomatic or kind of government level. This is not how things should work for primary prevention and for treatment of any disease.
Yeah, you're right, but this is unfortunately happening.
Happening, yes, I see that, and yes, it's sad. It's sad.
I think this has been happening from a while. At least I have read a few papers, and they were published in early 2000s. Some like all those deportees from Middle East.
I see. Okay.
And I would also like to mention that some of the patients who do come positive for syphilis serology, even they are treated, and obviously their test does not become negative, and they remain positive throughout their life. They are not allowed to work in some of the countries in Gulf. So there are issues with various diseases.
Okay. With that, I think we will conclude the session. It was awesome, and the presentation by all of our presentations were great. And I think we especially thanks Dr. Gilani and Dr. Jamil, as well as all the organizers and APPNA-MERIT, and most importantly, our panel, and even more importantly, by our audience. It was a very active participation. At one stage, I saw more than 90 people in audience. It was wonderful. I think we will continue with that, that tradition and our commitment.
Thank you, everyone. Thank you all presenters, Dr. Naseem, Dr. Faisal, Dr. Somya, Dr. Saima, Dr. Bushra Jamil. Thank you very much.
Thank you. Good night.
Thank you.
Bye-bye.
Thank you.
Thank you.